cerebrospinal fluid or the CSF is a very clear colorless fluid which is rich in protein and glucose, and this covers the brain. Okay, so there is first layer of brain and it is covered by a layer of pia matter. Then over that there is arachnoid, and over the arachnoid there is dura matter, and this dura is the thickest one, thickest covering. So dura, arachnoid and pia. Okay, and brain, covering the brain, and this is subdural space, subarachnoid space. Okay, and over this, after dura there is a bone is there, skull bone. Okay, so this CSF or the cerebrospinal fluid, it is held in the subarachnoid space. Okay, so in this space filled with the CSF, and actually this CSF is filling all around the brain along with the ventricles, and also it is going to the. If there is a defect of this dura along with the skull and also the nasal mucosa. Okay, here there is a nasal mucosa also. So from here, see the defect in the arachnoid, then this dura matter, the skull and also the mucosa. Then what will happen? This CSF will leak into the nasal cavity. Okay. Okay, so this will go into the nasal cavity. So CSF in the subarachnoid space with the defect in the dura matter, the skull bone and the mucosa will leak into the nasal cavity, and that is called CSF rhinorrhea. Okay, so today's class is on CSF rhinorrhea. Though it is very easy, as I am getting so many requests, we will go through the etiology of that, then what is the presentation of CSF rhinorrhea, how will you evaluate it, and what is the management options. Okay, so this CSF can leak from all the areas, not only from the anterior cranial fossa, but so if it is from the anterior cranial fossa, then the leak can be through the defect in the cribriform plate, or it can be a defect in the frontal sinus or the ethmoid roof, or through the sphenoid bone. Okay, so in that case it will directly come into the nasal cavity. But if it is from the middle cranial fossa or from the posterior cranial fossa, how will it come into the nasal cavity? So that is through the defect in the mastoid cavity, then into the middle ear, and from there through the eustachian tube this can come into the nasal cavity. Okay, so the defect can be in the anterior cranial fossa, or it can be in the middle cranial fossa, or it can be in the posterior cranial fossa. And if it is in the anterior cranial fossa, I already told you that it can be, the leak can be very easily, it can go through the cribriform plate, defect in the cribriform plate, or through the frontal sinus or the ethmoid roof or the sphenoid sinus. And from middle and posterior it is through the mastoid cavity, then to the middle ear, and from there through the eustachian tube it can come into the nose. So what are the causes of this CSF leak? The causes of CSF rhinorrhea, so many authors have given varied classification, and this classification is from Scott Brown textbook, which is based on a meta-analysis published in Laryngoscope. Okay, and the most widely quoted author for classification is from Omaya. Okay. So we can divide the causes of CSF rhinorrhea into congenital as well as acquired. Okay. So congenital and acquired. Under congenital we have the meningocele, meningoencephalocele, then congenital skull base defect and also congenital hydrocephalus. Okay. So basically it can be encephalocele or a meningoencephalocele, congenital skull base defect, or it can be a congenital hydrocephalus, in which there is raised ICP causing a CSF rhinorrhea. Or it can be acquired. Acquired again we can divide into idiopathic for the reason is not clearly known, or it can be traumatic, or it can be inflammatory, or it can be due to neoplasms. Okay, so idiopathic, traumatic, inflammatory and neoplasm. And trauma can be again divided into surgical causes and non-surgical trauma. Okay, for this idiopathic, the cause is unknown, but the most accepted theory or the reason behind an idiopathic is that there are some areas of weakness in the skull base. So if the intracranial pressure is raised, the dural pulsations will be high. So there are some areas of continued dural pulsations, and this will cause erosions in some areas. And if the skull base in some areas are already weak, these pulsations will cause erosions of that area, and later the herniation of this dura along with its layers can happen. Okay, so that is the reason, most accepted reason behind an idiopathic. So that is an raised intracranial pressure, or even the idiopathic is otherwise called spontaneous CSF leak. Okay, and in surgical the most common one is an intranasal polypectomy or headlight polypectomy. Then it can also happen with endoscopic surgeries, including endoscopic sinus surgery, or it can be transcranial surgeries even to the middle or the posterior cranial fossa. Okay, and in non-surgical, mainly due to head injuries, that is skull base fractures, open or penetrating injuries to the skull base, or it can be a post-traumatic hydrocephalus. Hydrocephalus or post-traumatic hydrocephalus. The reason again here, the same reason. So the raised ICP causing continuous dural pulsations leading to bone erosion and later herniation of the dura along through the defect. Inflammatory, it can be either an erosive lesion due to an mucocele or nasal polyposis or cystic fibrosis, fungal sinusitis or osteomyelitis, or it can be post-infective hydrocephalus again. Okay, so it can be erosive lesions or post-infective. Because of all this, it can lead to an hydrocephalus, which lead to increased ICP. And in neoplasm, it can be a neoplasms of the skull base, which neoplasm involving the skull base, or it can be intracranial neoplasm leading to formation of hydrocephalus. Okay, so these are the causes of an CSF rhinorrhea, and historically the most common cause was considered to be head trauma, but presently the most common cause is considered to be an iatrogenic or surgically produced. Okay, the iatrogenic CSF rhinorrhea is recently the most common cause is an iatrogenic CSF rhinorrhea. The iatrogenic leak is the most common cause, and of that the functional endoscopy sinus surgery contribute to around 0 to 2.5% of all the causes of reasons for a CSF leak. Okay. The epidemiology of CSF rhinorrhea, I already told you, the most common cause being the iatrogenic trauma, and the commonest site is ethmoid roof or the cribriform plate. Roof of ethmoid or the cribriform plate, which contribute to around 58%. The second commonest is a sphenoid, that contribute to around 33% through the sphenoid sinus. Then the frontal, especially the posterior wall of frontal sinus, contribute to around 7%, and the cellar or the clival leak contribute to around 2%. Okay, and of this, the spontaneous CSF leak is more common in females, and that too obesity and at the age of 40s, and obesity will contribute to this spontaneous CSF leak, whereas the traumatic CSF leak is more commonly seen in males. Okay, so traumatic male, spontaneous females, and also the age of around 40 years and obesity will contribute to that. So regarding this, there is a sites. Okay, site of CSF leak. So why we are so much bothered about the CSF leak? One, because this brain parenchyma is happily resting in an area filled with with a fluid cushion. Okay, because of the CSF filling that areas around the brain, it is resting on a fluid cushion. So if this fluid cushion is lost, there is chance of a direct trauma to the brain parenchyma. That is one. Second, the nose is a highly contaminated area, so there is chance of life-threatening infection spreading into the brain, development of meningitis, and in a study shows around 5.6 to 60% chance of development of meningitis after an attack of CSF rhinorrhea. Okay, so chance of meningitis. And the CSF leak will not happen immediately after sustaining a trauma. Why? Because this hematoma will form over the fractured area, and only after dissolution of this hematoma, then if the fracture line or the fracture site is persisting, fracture is persisting, then there will be leak. So that can be a delayed CSF leak also. Okay, so that is why it is important to diagnose and give proper management in a case of CSF leak. So how will you manage a case of CSF leak? The first thing is a proper diagnosis, because there are so many differential diagnoses which can mimic a CSF leak. The differential diagnosis of CSF rhinorrhea, the most common being an allergic rhinitis, then benign intracranial hypertension, carotid or vertebral artery dissection, infective etiology, the commonest being a common cold, meningitis, subarachnoid hemorrhage, vasomotor rhinitis, then sinus diseases or the spinal diseases, brain tumors, and also this post-traumatic headache, and in some cases an allergic rhinitis associated with a migraine which causes an headache can mimic or feel a CSF leak. So we want to approach the CSF leak in a very systematic way for getting a correct diagnosis. So we have to elicit a proper history, then correct clinical examination of the patient, and also laboratory investigation of the CSF fluid, and imaging, and also intrathecal dyes and markers. So we can see one by one. So the first one is a clinical assessment, and this clinical assessment include history taking, nasal endoscopy and otoscopy. So this accurate clinical history taking is very important. Most of the cases the patient will be complaining of clear rhinorrhea, and it can be either an intermittent or continuous. Usually it is unilateral, but it can be bilateral also. And this CSF rhinorrhea leak will be increased on straining, and you can elicit a reservoir sign on bending the head, and usually this is associated with a headache. Headache is usually seen in around 40% of cases, or it can be associated with a neck pain or neck stiffness. And if it is an if this CSF leak is due to a benign intracranial hypertension, there can be chances of visual disturbances, pulsatile tinnitus, and also balance disorders. Okay, and there will be a prior history of most of the cases. There will be a history of either a surgery or a trauma to the head. Or in some cases, a recurrent attacks of meningitis will be the only symptom or an only information which point towards a CSF leak. Okay, and do a nasal endoscopy in an outpatient basis, and in around 36% of cases you can clearly find out the exact site of CSF leak, or an associated meningoencephalocele or a meningocele if present can be found out by a nasal endoscopy. And otoscopy is also very important because it can in the ear you can see middle ear effusion if the cause is because of fracture of the middle cranial fossa or the posterior cranial fossa. Okay, so under clinical assessment include comes history, nasal endoscopy and otoendoscopy. From the history and by endoscopy, if you have got an increased suspicion of a leak, then go to biochemical testing of the drainage. Historically, we had the halo sign, that is taking the discharge in a tissue paper or on a handkerchief and allowing it to dry and looking for the halo. That is not at all done nowadays. And also we had done the drainage for glucose estimation. That is also highly unreliable, so this is not done nowadays. And the most reliable test of biochemical testing is beta-2 transferrin assay. Okay. Beta-2 transferrin assay, and this beta-2 transferrin is a protein found in CSF and also in the perilymph and also in the vitreous humor. So estimation of this is give a very good sensitivity and specificity. It has got a sensitivity of around 97% and this has got a specificity of around 93%. Okay, but this can give false positive results in conditions like inborn errors of glycogen metabolism, neuropsychiatric illness and rectal carcinoma. All these are false positive, will give false positive result for a beta-2 transferrin assay. So we also have a beta trace protein. This is a recent advance beta trace protein assay, which has got a sensitivity and specificity of around 100%. The beta trace protein assay is comparatively cheaper and rapid test than this beta-2 transferrin assay. So by beta-2 transferrin assay and beta trace protein, these are the two biochemical tests. Either you have confirmed your diagnosis or there is a persistent clinical suspicion. You can go with the imaging. So in the algorithm, next is imaging studies. And in the imageology, the CT scan, that is high resolution CT scan, which is non-contrast and in multiplanar reconstruction is highly reliable. Earlier we were taught as doing a CT scan, CT cystonogram. Isn't it? CT cystonogram with metesamide and also the newer iohexol as a dye. But this is not at all used nowadays because of there are so many possible complications, and this CT cystonogram is of no use in case of inactive leak. So if at all do a high resolution CT scan of 1 to 2 mm cuts, that is in bone algorithm, And in the coronal cut you will get skull base defect, and in the axial sections you get the posterior wall of frontal sinus and also the sphenoid sinus. And that is helpful in 84% of cases in a large series for identifying the site of leak. And MRI in T2 weighted image is also complementary to this CT scan. Okay, so MRI scan with the T2 weighted images. This is very helpful in finding out herniations, especially the meningocele and meningoencephalocele, which is very useful before planning a surgery. And also there are some particular features in case of raised intracranial pressure that you can find out by doing an MRI scan. And the most predictive sign is flattening of the posterior aspect of the globe with a specificity of 100% and a sensitivity of around 43%. So that you can find out by doing an MRI scan. Okay, so especially by doing a CT scan, if you find out any dural herniations, go with an MRI scan. And this MR cystonogram is a non-invasive extension of the standard MRI. So all these are non-invasive techniques, and by doing this you have a very high suspicion of clinical suspicion of CSF leak, but you are not getting a positive result by doing this. Then it is better to go with an invasive investigations with intrathecal dyes, intrathecal fluorescein or a nuclear cystonogram. The most commonly used dye is again fluorescein. So for that you first do a standard lumbar puncture and take 10 ml of CSF. To that add 0.25 ml of 5% fluorescein, and through a polymedic pencil point spinal needle introduce it and keep the patient in Trendelenburg position for 1 hour, and after that do an endoscopy, or you can plan it 1 hour before surgery, and at the time of surgery with an endoscope you can see the fluorescent dye coming if there is an active leak, and you can increase the visibility by putting a blue light filter along with the endoscope light source, or you can ask the anesthetist to do a Valsalva maneuver, or if you are doing under local anesthesia you can ask the patient to cough. Okay, so that is regarding fluorescein. So this is the algorithm of diagnosis of a CSF rhinorrhea. That is, the first one is by clinical assessment, that is I already told you, by high degree of suspicion, a very good history taking, and nasal endoscopy and otoscopy. So if there is an increased suspicion you can go with the biochemical testing, mainly beta-2 transferrin assay and beta-2 trace protein. Okay. Again there is a high degree of suspicion, you can go with a high resolution CT scan with the which is non-contrast and in multiplanar reconstruction. And if you find out an encephalocele, or if you are suspecting an intracranial increased ICP, go with an MRI, or you can go with an MR cystonogram. Okay, especially if there is an meningoencephalocele or an encephalocele. But if this is negative, with all this, if the leak is negative but there is a high degree of suspicion, negative leak, invasive methods are there like an intrathecal fluorescent dye injection or a CT cystonogram, which I have already told earlier, or you can go with a nuclear cystonogram. So this is how you have to diagnose a case of CSF leak. So by doing all this you came to a diagnosis of CSF rhinorrhea and also localize the leak. Then the treatment of choice is surgery. There is no confusion in that. Whether to give a preoperative antibiotic or not is still a matter of controversy. Some authors are in favor of giving broad spectrum antibiotics. Some others advise towards vancomycin. But you can follow the protocol in your institution. And one of the most common reason for failure of CSF leak repair is coexisting or an associated raised ICP. Okay, so that you can diagnose by doing an MRI scan by certain features like flattening of the posterior globe or an empty cella or arachnoid slit or a compressed ventricles or optic nerve protrusion, etc. And whether to go for a CSF diversion or drainage on a temporary or a permanent basis is again a matter of controversy. But in surgery, traditionally there were two techniques. One is an craniotomy or an extradural external approach, and the most accepted one and the surgery of choice is an endoscopic repair. So what are the steps of an endoscopic repair of CSF leak?